First of all, I welcome you all this evening on behalf of Chest Council of India. Before we take this evening ahead, let me take opportunity to introduce myself. Well, I am Dr. Ram Narayan Saha, consultant pulmonologist practicing here in Kathmandu at private hospital. I am blessed and honored to be part of this webinar. I must thank Founder President N.S. Krishna sir and Narayana Pradeep and all my senior colleagues and CCI family members who has given me opportunity to moderate these sessions. On behalf of Chest Council of India and as a life member of organizing committee, I do hereby welcome the distinguished speaker, Professor Dr. Ashwini Kumar Mahapatra, who is professor and head of pulmonary medicine department at Kasturba Medical College, Manipal. He is also involved in bedside teaching, case discussions, and seminars. He is also head of the Board of Studies pertaining to pulmonary medicine and also involved in OPD cases, daily ward rounds, and case-related procedures such as fiber optic bronchoscopy, allergy testing, sleep lab, spirometry, and managing patient in ICU setup. He is going to talk on vaccination in adult pulmonary practice. Sir, you please.
Good evening, everybody. A warm greetings from Manipal. At the outset, I thank Chess Council of India, CCI, for giving me opportunity to speak on today's topic. So today's topic is a very fascinating one. So I am briefed about to tell about the vaccinations in adult pulmonary practice. So as a chest physician or a pulmonologist, we deal with a lot of chronic lung diseases in day-to-day practice. So if you see our practice, if you see the basket of pulmonary practice, the two diseases come into our picture. That is one COPD and other one is asthma. Because COPD and asthma are the bread and butter in our clinical practice. So what I'll be doing in next 40 to 45 minutes, I will brief you something regarding the vaccination in COPD and asthma, because these two are very fascinating events. Because in day-to-day practice, we'll use a lot of vaccination. So I'll be mainly concentrating my focus on pneumococcal vaccination and influenza vaccination. So before starting the topic, let me elaborate a little bit about the burden of COPD globally and in our country. So coming to the chronic lung diseases in India, India has a disproportionately high burden of chronic respiratory diseases. There is an increasing contribution of the diseases to the overall disease burden across India. So more than 330 million of people suffer from asthma, about a tenth of those living in India. COPD is the second biggest cause of death in India today. So the magnitude of the problem or the mortality of the patients dying of COPD is quite high in a country like India. So this is a graphical representation of burden of chronic lung diseases in India. If you see the graph or the picture or the pictorial, the North Indian population are more burdened with chronic lung diseases. Similarly, some South Indian states, they are also quite burdened with the chronic lung diseases. So coming to the COPD burden, just a little highlight about the COPD burden in our country. So COPD is currently the fourth leading cause of death, and it is projected to be third by the year 2020. So this millennium or this century is going to end. So it is going to be the fourth leading cause or third leading cause of death by 2020. So in 2015, COPD caused 2.6% of global DL wise, that is called disability adjusted life years. So it is the fifth leading cause of loss of DL wise in the globe. So across the world, India has one of the highest mortality rates due to COPD. So the death rate due to COPD is quite high. So coming to the vaccination aspect, why at all we require a vaccination? Because since we are dealing with a lot of chronic diseases like COPD and asthma, vaccination is very important in our day-to-day clinical practice. So in what way vaccination helps? Vaccination helps in prevention and control of the disease process. It worsens because the childhood vaccination worsens as the person enters into the adult life, and it also decreases the morbidity and mortality due to the disease process, because the COPD patients, they're very prone to develop community acquired pneumonia by Streptococcus pneumoniae, which is a very hazardous condition, and the mortality due to community acquired pneumonia is very high throughout the globe and throughout the India also. So coming to some of the pathogens that were responsible for COPD exacerbation, as we all know, coming to the bacteria, the H. influenzae, Streptopneumonia, Moraxella, and Pseudomonas, they are the most common offending organisms or the bugs or the bacteria which cause a COPD exacerbation. Similarly, coming to the viruses, the common virus which is involved in a COPD exacerbation is an influenza virus. So you have to tackle these bugs, and you have to give an effective vaccination to in order to prevent the patient for a recurrent exacerbation. When the exacerbation is limited, the number of visits to the hospital comes down, and there is less admission in the emergency care unit also. So what is the impact of COPD exacerbation? Definitely a patient of COPD with exacerbation, there is a decrease in quality of life. There is COPD causes increase in the inflammation. There is a faster disease of progression, increase in childhood hospital. There is an increased likelihood of hospitalization. There is an increased risk of recurrent exacerbation, and there is an increased mortality rate. So the impact of COPD exacerbation in day-to-day practice is quite magnanimous. So we have to control the exacerbation, and to control the exacerbation, we have to have an effective vaccination program, or we have to have an effective vaccination to tackle the disease and to tackle the exacerbation. Now coming to the asthma. What is asthma and the risk of infection? Asthma and other atopic conditions, there is an increased risk of serious and common infections with both viruses and bacteria. There is impairments in innate immunity in the airways, and there is a decrease in adaptive immune functions in some asthma patients. Because asthma patients, they are very prone to secondary infection. When there is a secondary infection, there is an exacerbation, and the patient comes back to the hospital. So asthma as a risk factor for invasive pneumococcal disease. So asthma is an independent risk factor for invasive pneumococcal disease. Should you require a vaccination or a pneumococcal vaccination for an asthma patient? Routinely, if you say it is not required. Even the GINA guidelines also tells that a routine pneumococcal vaccination is not required for asthma patients. However, if a chronic persistent asthma, those asthma who are having a fixed airway obstruction or there is a widespread fibrosis, those patients may lead to a COPD, and those patients may require a pneumococcal vaccination. So asthma is not a direct risk factor for invasive pneumococcal disease, but asthma is an independent risk factor for invasive pneumococcal disease. Now coming to the vaccination, little bit about the vaccination. What is the history of vaccination? When you talk about vaccination, one person comes to our mind, that is Sir Edward Jenner. So he is the pioneer in vaccination. So he had introduced successful vaccination in 1796. So coming to Louis Pasteur, he was a French biologist, microbiologist, and the And he actually developed the principle of vaccination through pasteurization. So as for him, when meditating over a disease, I never think of finding a remedy for it, but instead a means of preventing it. So Louis Pasteur was the person or the scientist or the French biologist who had initially told that you cannot control a disease process, but you can prevent a disease process. So now coming to the adult immunization in India. So adult immunization is a highly neglected and under publicized issue in our country. Even among publicized guidelines from international organizations such as WHO, there is a dearth of consensus regarding the optimal strategy for adult immunization. So it is a neglected area in our day-to-day practice, adult immunization. So what is the importance of adult immunization? Definitely, it prevents and controls the disease and it creates a healthy growth. So routine immunization also provides a chance of health visit. So if you are giving immunization, there is a better chance that the patient comes back to your clinic on day-to-day basis. There is a winning immunity of the childhood vaccines because the effect of the childhood vaccines, they decrease gradually. Successful universal immunization has resulted in decrease in mortality and morbidity in children. Why to vaccinate adults? Is it required? Yes, it is required because vaccination is required in order to prevent the disease process. So successful universal immunization has resulted in decrease in mortality and morbidity in children. Adolescents and adults have become more susceptible and prone to get vaccine preventable diseases. In our national schedule, only tetanus toxoid vaccine is included at age 10 and age 16 years, and the coverage is extremely poor. No adults are given any preventive vaccination routinely because in our country, the adolescents and the adults, they constitute 70% of the Indian population. What are the common barriers of adult vaccination? So there is an unaware of the need for vaccination by self, parent, physician, and the pediatrician because the patients don't understand the importance of vaccination, nor the effect of vaccination is being told in a proper way to the patient. So there is a prevention health checkup visit not done and there is a not compliance. Adolescents and adults underestimate the risks of vaccine preventable diseases. Problems related to verification of past vaccination history. If you ask the vaccination history of the patients, they seldom remember their previous vaccination history. Fear about vaccine reactions and myth that once vaccinated in childhood, lifelong immunity remains. That is not true because the concept is that the feeling is that once you are vaccinated in the childhood, the effect persists throughout the life. It is a myth. So it is a misnomer. So no national schedule of adult vaccination in India and low adherence recommendation of existing guidelines on vaccination. One of the most important reasons adults identify for not receiving vaccine is the lack of a provider recommendation for the vaccine. This was told by the CDC, that is Center for Disease Control, because there is no fixed guideline or recommendation for a vaccination or adult vaccination in any of the countries. So now coming to the burden of adult vaccine preventable disease, if you look at the pictorial, the burden of adult vaccination preventable disease is highest for influenza, followed by pneumonia. When you talk about pneumonia, it is a community acquired pneumonia. Then there is pertussis. Then the last come, that is the shingles. So this is the burden of adult vaccination preventable diseases throughout the world. What is the global mortality due to vaccine preventable diseases? This is, if you see the pictorial, the red one, that is pneumonia, is maximum. So the mortality due to vaccine preventable diseases is highest for pneumonia, followed by rotavirus infection, measles, all these things. But the mortality due to vaccine preventable diseases is highest for community acquired pneumonia. So coming to the high risk adults for invasive pneumococcal disease and flu, what the CDC says. So the adults 65 years or older are at increased risk. So when the patient reaches the age of 65, he or she is a high risk patient because there is a lot of chance of secondary infection and there is a lot of chance of exacerbation of the underlying disease process. Then comes the pregnancy. Some adults 19 through 64 years old are also at increased risk, including those with chronic illness like lung, heart, liver, kidney disease, asthma, with conditions that weaken the immune system. So the immunosuppressive conditions like HIV, AIDS, cancer, and asplenia, with cochlear implants or CSF leak, and those who smoke cigarettes. So the current smokers are also their high risk for adults invasive pneumococcal disease and flu. So coming to the population who are at risk of developing invasive pneumococcal diseases. So a patient of congestive heart failure, there is a 9.9-fold increase in development of IPD, whereas in a patient of chronic lung disease, the risk is much more higher. So the risk increases to 16.8-fold. So you can imagine the risk of invasive pneumococcal disease in a patient of chronic lung disease. Of course, all problems lead to invasive pneumococcal disease, be it alcohol abuse, heart failure, influenza vaccination, neurological disorders. But out of all the list, the chronic lung disease patients, they are at heavy risk of developing invasive pneumococcal disease. So now I will come to the vaccination proper. When you talk about the vaccination, two diseases come to our mind. One is a COPD and one is a asthma. So for COPD patients, the main vaccination which has been given is a pneumococcal vaccination. So I'll just briefly talk about the pneumococcal vaccination. What is the vaccination? What is the vaccination schedule? What are the Indian guidelines and how it changes from the ACIP guideline? So the pneumococcal disease, it can be an acute form or it can be chronic form. When it is an acute form, there can be sinusitis, rhinitis, all these things. But when there is a chronic form, it can lead to bacteremia, septicemia, all these things. So in pneumococcal disease or community acquired pneumonia can result in bacteremia, septicemia, and it can lead to type 2 respiratory failure also. So what are the major causes of community acquired pneumonia in people above age 60 years? Definitely it is a streptopneumonia. This is the bug which results in community acquired pneumonia. So this is the most offending organism or offending bug which leads to community acquired pneumonia in people aged more than 60 years. What are the age specific rates of hospital admissions by pathogens? So if you look at the graph, the highest is for streptopneumonia, because the streptopneumonia or community acquired pneumonia, there is a high rate of hospital admission. So as the age advances, the chance of hospital admission is more with patients of community acquired pneumonia. So the x-axis is the age group, the y-axis is the rate per 1 lakh population. So if you look at the graph, as the age advances, the hospital admission rates due to streptopneumonia goes on increasing. So again, coming to the mortality due to community acquired pneumonia. So as the age advances, the mortality rate also increases. So the age which is kept as a barrier is 65 years. So when the patient crosses the age of 65 years, the mortality due to community acquired pneumonia also increases. So that there is a high mortality as the age advances. What is the need for pneumococcal vaccination? Why I tell you give a pneumococcal vaccine to a patient? Of course, COPD is the main disease for which pneumococcal vaccination is required, but there are certain other conditions where you can advise your patient a pneumococcal vaccine. So pneumococcal disease are very serious and it can lead to death also. 1 out of every 20 adults who gets pneumococcal pneumonitis or pneumococcal pneumonia, it dies. So 2 out of every 10 adults who get bacteremia, they die. 3 out of every 10 adults who get meningitis, they die. So you can see the magnitude of the problem, the magnitude of the organism which is causing invasive pneumococcal disease. So coming to the vaccine, there are two types of vaccines which are commonly being used. One is a polysaccharide vaccine, other one is a conjugate vaccine. So the polysaccharide vaccine is called PPSP23. So it has got 23 serotypes. These are the number of the serotypes, very difficult to remember, but it has a wide serotypes. It is 23 serotypes and it is not protein bound. So the 23 valent pneumococcal polysaccharide vaccine was licensed in 1983, replacing the 14 valent vaccine which was introduced in 1977. Vaccine serotypes account for 86% of the bacteremia, 83% meningitis, and 65% of AOM among less than 6 years of age. Immunity is induced primarily through stimulation of B cells, which release IgM without the assistance of T cells. So this is a vaccine which is mediated through the B cells of the immunological system, unlike PCB13, which is mediated by the T cells. So it mainly acts on the B cells. Now coming to the pneumococcal conjugate vaccine, PCB13, it is a protein-bound vaccine. It is a conjugate vaccine, consists of polysaccharide capsule covalently bound to a non-toxic mutant of diphtheria toxin and the protein CRM197 or protein D of non-capsulated HEAP or DT and TT, and finally main OMP, which is highly immunogenic but non-toxic. This combination provokes a significantly more robust immune response by recruiting CRM197 specific type 2 helper T cells, which allows for immunoglobulin type switching to produce non-IgM immunoglobulin and a production of memory B cells. So PCB13, it generates the memory B cells. It is a long acting. So PCB13, once you give PCB13, the effect lasts for a longer period of time because it stimulates or enhances the memory B cells. So it acts very profoundly and for a longer time against Streptococcus pneumoniae, and thereby it prevents the disease process for a longer period of time. So this is a beautiful picture, this is a beautiful table, so which says about the characteristics of pneumococcal vaccine. So PPSP23 and PCB13. So PPSP23 is an unconjugated capsular polysaccharide antigen, whereas 13 is a capsular polysaccharide antigen. 23 has got 23 serotypes. So 23 is a T cell independent immune response. It enhances the T cell activity. So the IgM antibody is produced. The response declines in 3 to 5 years and no amnestic response at revaccination. It has a considerable efficacy proven against invasive pneumococcal disease, that is 50 to 70%. Unclear efficacy against non-bacteremic pneumococcal pneumonia. No efficacy is demonstrated in reducing the nasopharyngeal caries. No impact provided in reducing overall pneumococcal disease burden. Whereas PCB13, it has got a very high efficacy rate, almost 80 to 90%. At present, the relatively small serotype coverage for IPD in the elderly, and it acts by enhancing the B cells. So coming to the immune response, PPB23 or PPSP23 is T cell independent, whereas PCB13, it has got a T cell response. It is a poor inducer of immunological memory. There is immunologic priming and memory response is greater in PCB13. The duration of protection in 23, PPPS23, there is a high antibody titer for 1 to 2 years, which went over 5 to 10 years. But in case of PCB13, at least 2-3 years, but no longer. So revaccination, coming to the revaccination in case of PPSP23, 5 years after the first dose for individuals who are at risk. PCB13, the revaccination is not recommended following an age-appropriate primary series. Now coming to the dose and administration, how you are going to give the vaccine. So both PCB13 and PPSP23, they're available as 0.5 ml suspension, and they're available with pre-filled syringe. Coming to the PCB13, 0.5 ml suspension of intramuscular injection is supplied in a single dose pre-filled syringe. In adults more than 18 years, the vaccine should be administered as a single dose. Preferred sites of administration is the anterolateral aspect of the thigh in infants, or the deltoid muscle of the upper arm in toddlers, children, and adults. It is not to be injected in gluteal area where there is a abundant major nerve trunk or blood vessels are there. PPSP23, it has to be given 0.5 ml. It has to be administered intramuscularly or subcutaneously. So there is a difference. In case of PCB13, the administration is always intramuscular, whereas in case of PPSP23, the administration can be either intramuscular or subcutaneous routes. What are the ACIP recommendation? ACIP stands for Advisory Committee on Immunization Practice. So what does ACPA recommend regarding the vaccination schedule? So as per the ACIP 2019 recommendation, the PCB13 and PPSP23 vaccines should be given to the adults who are more than equal to 65 years of age. So as per the ACIP 2019, both the vaccine should be reserved for adults who are more than equal to 65 years of age. So coming to the CDC ACIP recommendation, the CDC ACIP recommends pneumococcal vaccination for all high-risk individuals more than equal to 2 years of age. So CDC has little tweaked the vaccination schedule. So PPSP23 is the only vaccine recommended by ACIP for majority of immunocompetent patients who are less than 65 years of age. So you can see the risk group. If it is an immunocompetent person, underlying medical condition is there, PCB13 is not recommended. PPSP23 is not, PCB13 is recommended. Whereas in case of chronic lung disease, PPB23 is recommended. So you can give PPSP23 vaccine to all risk groups who are immunocompetent and who are having an underlying medical condition like chronic lung disease, heart disease, diabetes mellitus, alcoholism, liver disease, and current smokers. So in all this category of patients, these are all immunocompetent persons, but there is a recommendation of PPSP23 in this type of group of patients. So what are the recommendations for PCB13 and PPSP23 among adults more than equal to 19 years of age? Again, the same things. If the person is having comorbid conditions like heart, liver, lung disease, smokers, in those kind of patients, you can give PPSP23 vaccination. So how to evaluate it? So pneumococcal vaccine, naive persons aged more than equal to 65 years. What is called a naive person? Naive person means you have to believe that person, and in that person vaccination history is not available. So when the age is 65 or more, you have to give a PCB13 vaccine followed by PPSP23 after 1 year. So the gap between PCB13 and PPSP23 should be 1 year. Persons who previously received PPSP23 are the age more than equal to 65 years. So in those category of patients, first you give PPSP23 followed by PCB13, but the gap should be more than equal to 1 year. So you have to maintain the gap because the gap is very important. So after 1 year of giving PPSP23, you have to vaccinate the patient with PCB13. So persons who previously received PPSP23 before age 65 years and who are now aged more than equal to 65 years, so you have to give PPSP23 patient already received before the age of 65 years. After 1 year, you have to give PCV13. After 1 year, you have to give PPSB23. But the last vaccination of PPSB23 and the previous vaccination of PPSB23, there should be a gap of at least 5 years. So if the patient has been vaccinated with PPSB23 before 65 years, once the patient crosses 65 years, you have to vaccinate with PCV13 after a gap of 1 year. Then after a gap of 1 year, you have to give PPSB23. But the time limit between two PPSB23 vaccination should be at least 5 years. You have to maintain that gap. What are the Indian guidelines? Because there was a Indian consensus guidelines which came out in 2020. It was a brainchild of top pulmonologist of India. So there is a little tweak or little difference between the Indian guidelines and the ACIP guidelines. The ACIP guidelines are based on the fact that in the United States, PCV13 is being administered to all children since the year 2010, and therefore there is a herd immunity because as per the ACIP recommendation in USA, all children they're being vaccinated with PCV13 after the year 2010. But in India, pneumococcal vaccination in pediatric immunization schedule has only been incorporated recently. Thus, the concept of herd immunity is not applicable. Hence, for individuals aged 19 to 16 years, immunocompetent patients, vaccination with PCV13 followed by PPSB23, but the gap should be more than equal to 8 weeks. So in Indian population, those who are 19 to 64 years, immunocompetent patients, first you give PCV13. After 8 weeks, you vaccinate with PPSB23. So the PCV13 vaccination first has to be given, followed by PPSB23. Again, coming to the Indian guidelines, repeat vaccination with PPSB23 causes hyperresponsiveness. So you should not repeatedly vaccinate the patient with PPSB23 because if you repeatedly vaccinate with PPSB23, there is a chance of hyperresponsiveness is there. And hence revaccination of an individual with PPSB23 must be solely based on clinical judgment. PCV13 is recommended first as it amplifies the anti-pneumococcal response to subsequent administration of PPSB23 for many vaccine common serotypes. PCV13 and PPSB23 can be administered concomitantly with all other recommended vaccine. A gap of at least 8 weeks be maintained between the two vaccines and that they should not be given simultaneously. So if you want to vaccinate with two vaccines, you have to maintain a gap of at least 8 weeks. First PCV13 followed by PPSB23. What are the other recommendations? WHO recommendation, again, there is a confusing type. WHO recommends that is the PPSB for select age groups more than equal to 2 years of age with increased risks of pneumococcal disease, because WHO recommends the PPSB to be given from age 2 years onwards. What is the efficacy of pneumococcal vaccine? Definitely the efficacy of pneumococcal vaccine is very high in case of chronic lung diseases. So if you look at the pictorial for COPD, the efficacy of pneumococcal vaccine is around 65%. For diabetes mellitus, it is 84%. Coronary artery disease, it is around 73%. What is the result of simultaneous influenza and pneumococcal vaccination? Definitely there is a confounding effect. So simultaneous coverage offers 63% reduction in hospitalization and there is a 81% reduction of death due to if you give both the vaccination together. Now coming to the influenza vaccination. So influenza vaccination is usually advocated for bronchial asthma patients. Similarly, because asthmatics, they keep on coming to the hospital on day-to-day practice. So it is especially reserved for asthma patients. 3 types of influenza viruses that is type A, type B, and type C. Out of these three, type B undergoes antigenic drift, and type C is a stable virus. Only type A and type B causes significant illness and epidemics. Type A mutates easily. 16 HA subtypes and 9 NA subtypes are known to exist. So coming to the influenza vaccine, it was first available in 1940. Two types of vaccines are now available. One is a trivalent vaccine, other one is a quadrivalent vaccine. So it is an inactivated injectable vaccine. It is live attenuated. Coming to the trivalent vaccine, two subtypes A strains, that is H1N1 and S3NT. One type B strain, two formulations per year, one for each hemisphere, because this is a little complicated. Influenza vaccination is completely complicated. You have to have formulation as per the northern hemisphere and as per the southern hemisphere. Vaccine viral strains grown in embryonated chicken eggs. So what are the influenza vaccinations available in India? The following pre-filled syringes of influenza vaccines are available in India: trivalent inactivated vaccine, quadrivalent inactivated vaccine, and there is a live attenuated nasal spray, that is a lyophilized nasal spray. What is a quadrivalent influenza vaccine? It is the first intramuscular quadrivalent influenza vaccine. It has to be given 3 years of age and older. The recommended dose is 3 to 8 years, 2 doses, 0.5 ml each IM, at least 4 weeks apart. 9 years and older, there is a single shot of 0.5 ml vaccine that is given intramuscularly. The adverse events constitute injection site pain, headache, fatigue, and myalgia. What about the seasonal influenza vaccine? It is a trivalent recombinant vaccine for active immunization against influenza subtype A and B type in adults 18 to 49 years of age. Single 0.5 ml intravascular injection. Adverse events noted for injection site reactions, headache, fatigue, and myalgia. Coming to the quadrivalent influenza vaccine, it is an inactivated quadrivalent vaccine. It has to be given 6 months of age and older. The doses varies as per the age. So 6 months to 35 months, it is 2 doses, 36 months to 8 years, 2 doses, 9 years and older, single IM 0.5 ml injection. Approval based on immunogenicity studies in 1419 children, 6 to 35 months of age, and in 2101 children, 3 to 8 years of age. That is something called needle-free influenza vaccine. It is a trivalent inactivated influenza vaccine, 5 years of age and older. Safety and efficacy and immunogenicity established in randomized controlled trials. So the dose again depends on the age of the patient. Again, there is an intradermal quadrivalent vaccine. It is an inactivated quadrivalent vaccine against subtypes of H1N1, S3, N2, and B virus. It is approved for use in patients 18 to 64 years of age. Single 0.1 ml dose for intradermal injection. Which are the high-risk population for whom you have to give influenza vaccination? So it has been recommended by CDC that all children aged 6 through 59 months of age should be given influenza vaccination, especially those patients who are having allergic rhinitis and bronchial asthma. All persons aged more than 50 years, adults and children who have chronic pulmonary, cardiovascular, renal, hepatic, neurologic, hematologic, or metabolic disorders. Persons who are immunocompromised due to any cause, like human immunodeficiency virus infection or any other drugs. So those category of patients, they constitute the high-risk individuals, and those category of patients you have to vaccinate with influenza vaccination. Again, the women who are or will be pregnant during the influenza season, children and adolescents who are receiving aspirin or salicylate containing medications and who might be at risk for experiencing rare syndrome after influenza virus infections, residents of nursing homes and other long-term care facilities, persons who are extremely obese, whose BMI is more than equal to 40. These are all high-risk individuals because those patients or those category of individuals require an influenza vaccination. What is the recommendation in India? So one dose every year is recommended. We have to remember that thing because the high risk category of patients should receive an influenza vaccine once in a year. For inactivated vaccine, 0.5 ml is administered intramuscularly in the deltoid area. The trivalent vaccine provides protection against 2 strains of influenza A virus and 1 strain of influenza B virus, whereas a quadrivalent vaccine provides protection against 1 additional influenza B strain. So as a clinician, what is the choice? Whether you should go for a trivalent vaccine or a quadrivalent vaccine, it depends. Trivalent vaccine is more than enough because it is covering both strains of influenza virus, whereas the quadrivalent vaccine, it is covering only 1 additional influenza B strain. What are the interventions to improve adult vaccination coverage? What are the pitfalls? What are the drawbacks? Why it is not getting implemented correctly in our country or globally? Number one, there is a client reminder and recall system. The patient forgets when he or she has taken the last vaccination. Even as a bridging clinician, also you cannot follow the patient regarding vaccination. For that, proper documentation is required. Electronic medical records are required. So there should be a computer notification, flow sheet or checklist, flagging of medical records with stickers or stamps. There should be standing orders. So allow all non-physician personnel to prescribe or deliver vaccine using a protocol. It doesn't mean that a physician should give a vaccination. The order should be given by the physician. The patient can go back. They can take a vaccination from local places also. So the vaccine should be cheaper because it has been seen that the vaccines are very expensive. You talk about pneumococcal vaccine or influenza vaccine, these are very costly. So it should be pocket friendly to the patients. It should have an expanding access to the patients, increasing or changing hours when immunization services are offered. That should be express lane for immunization. Suppose a patient has come in a busy OPD, there should be express lane for the vaccination because in the electronic medical record or the case sheet, the vaccination schedule is there for today. So the patient has come to the OPD or the basic clinic. So the patient should be pressed by express lane for immunization and it has to be done immediately. So what are the intervention to improve adult vaccination coverage? Screen for vaccines indications, recommend the vaccine, make the vaccine available in the office or clinic, patient reminder and recall system, standing order system. So these are the implementation or the intervention you have to undertake to have an effective vaccine immunization program. So small bit about Tdap vaccination in adult. There is a new update. So Tdap vaccination is a DPT vaccine. So it is a diphtheria, pertussis, tetanus vaccine. The recommended dose is 0.5 ml administered intramuscularly at the anterolateral thigh or deltoid muscles. So it has to be the booster effect lasts for 10 years. So adults who have completed their primary vaccination during childhood should receive a Tdap vaccine every 10 years. So every 10 years, because it has been incorporated in the adult immunization program. So every year, every 10 years, the patient has to take a Tdap vaccination. So what is the updated ACAP guidelines on Tdap vaccination? So regardless of the interval, since the last tetanus, diphtheria, toxoid containing vaccine, persons aged more than equal to 19 years who have never received a dose of Tdap should receive 1 dose of Tdap. So it is a must. And after 10 years, patient has to be revaccinated with Tdap vaccination. Now coming to the little bit of CDC gold and GINA recommendation for adult pulmonary vaccination. As per the CDC, influenza vaccination is yes, and it has to be taken every year during the winter season, and it is must for patients with asthma. COPD patients, it is your choice whether to vaccinate with influenza or not. Whereas pneumococcal vaccination, it is especially reserved for the COPD patients. You can have a PCV23 and PPSP23. What our gold guidelines is, influenza vaccination reduces the serious illness and death in COPD patient, that is evidence B. 23-valent pneumococcal polysaccharide vaccine has been shown to reduce the incidence of community-acquired pneumonia in COPD patients who are aged more than equal to 65 years with an FEV1 less than 40%. In the general population of adults more than 65 years, 13-valent conjugated pneumococcal vaccine or PCV13 has got a higher efficacy in reducing the bacteremia and serious invasive pneumococcal diseases. GINA 2020 guidelines, what it says, advise patients with moderate to severe asthma to receive an influenza vaccination every year, that is evidence C. So if a patient is having asthma, GINA 2020 guidelines tells that the person or the patient has to be vaccinated every year with the influenza vaccine. There is insufficient evidence to recommend routine pneumococcal vaccination in people with asthma, that is evidence D. As I told earlier also, routinely asthma patients, they don't require pneumococcal vaccination, but if it is a long-standing asthma, chronic persistent asthma, or fibrotic ABPS stage, you can give a pneumococcal vaccination to the patient, but influenza vaccination is must for all asthmatic as per the GINA 2020 guideline. So little bit about COVID-19 vaccination, because COVID-19 vaccination is in an experimental stage. A lot of researches are going on. I'm not going to tell anything about COVID-19 vaccination. It will be unfair for me to talk about COVID-19 vaccination at this stage. But just for a routine sake, I'll just one or two slides, I will speak little bit about FDA criteria for COVID-19 vaccine, because the vaccine is still not in clinical practice. It is in the research stage. It has not come to the market. But just one or two slides, I'll speak about FDA criteria for COVID-19 vaccine. It demonstrates meaningful effects for intended population, inclusion of the adequate representation from all the groups, that is racial minorities, elderly adults, individuals with comorbidities, enrollment of specific populations such as pregnant women and frontline healthcare workers, recommending the use of randomized, double-blind, and placebo-controlled study designs, following the standards for the safety and effectiveness of a COVID-19 vaccine, post-license safety evaluations for COVID-19 vaccines, including the submission of a pharmacovigilance plan and post-marketing safety study. Endpoint estimate of at least 50% is a reasonable threshold for a COVID-19 vaccine. This is the FDA criteria which has been formulated regarding the manufacturing of COVID-19 vaccine. Number of pharmaceutical companies that are engaged in manufacturing the vaccine. Many vaccines are on the pipeline. Many of the vaccines have entered to the phase 3 clinical trial, but still it has not come to the clinical practice. That's why I'm not covering in my talk now. So what are the take-home messages? So if I summarize what I have talked till now, India has a substantial burden of asthma, COPD, and other chronic lung diseases for which effective vaccination can reduce the burden of infectious and acute exacerbation. Adult vaccination is being completely neglected. It is a neglected area. The guidelines says that 1 dose of influenza vaccination every year is recommended for an asthmatic patient. Indian pneumococcal guidelines are different from ACAP guidelines. PCV13 is recommended first in comparison to PPSV23. Physicians need to communicate the benefits of vaccination more effectively to their patients. Thank you. Thank you for a patient listening.
Thank you, sir, for your nice presentation. You
Thank
did
you. Thank you.
explain it very well, and the way of presentation and the way of explanation was really very good, sir.
Thank you. Thanks a lot.
And very amazing. And also there are so many questions from our participants and doctors, may I have some question? Dr. Dr. Kharad is asking a question. Does influenza vaccine contain H1N1 vaccine also? From Dr. Vinita Nalawade from Kharad. You
Yeah,
already mentioned it that yes. Yes, sir.
yeah.
Dr. Vinita Nalawade from Kharad.
Yeah, if you look at the influenza vaccine, there are four serotypes: A, B, C, and D. So A is it causes flu pandemic. B doesn't cause pandemic. C is a mild form, and D is seen in the cattle. So coming to the A serotype, it has again got two strains, H1, H and N. H stands for hemagglutinase, N stands for neuraminidase. So again, H has got 18 serotypes and N has got 11 serotypes. So coming to the question, so influenza A vaccine has got both coverage for H1N1 and S3N2 also.
There is also one question from Dr. Hitesh Saraogi from Ghaziabad. Vaccination guidelines for low socioeconomic status patients.
It's a very difficult question to answer. Uh, Actually, the vaccination should be just as per the setting in the clinical scenario, but there is no clear-cut guideline as per the low socioeconomic strata. And those patients who are high risk and those who are having age more than 65 years with lot of comorbidities and immunosuppression, definitely those candidates require a pneumococcal vaccination. And if you consider age 65 or more, those patients are more prone for invasive pneumococcal disease, and those patients should require at least one PPSP23 followed by PCV13. The gap should be minimum 1 year. But there is no clear-cut guideline which should be followed in a low socioeconomic strata, because you are the physician, you are judging the patient, you are seeing the patient. If you feel that the patient is a high-risk patient, underlying comorbid conditions are there, COPD is there, age is more, then you have to vaccinate the patient.
And also one question is from Nepal. Dr. Neeraj Nepal is asking one question. Is it important to vaccinate all patients in pulmonary practice? And why is it important?
See, pulmonary practice vaccination, actually vaccination is reserved for chronic lung diseases. Means if you look at the chronic lung diseases, definitely COPD, asthma, interstitial lung disease, diffuse parenchymal lung disease, bronchiectasis also come into the picture. But there is no clear-cut guideline for ILD or bronchiectasis patients, because bronchiectasis, we feel that if the patient is having a fixed airway obstruction, developing a COPD, definitely we should vaccinate a bronchiectasis patient with a vaccination. Otherwise, the vaccination in our adult clinical practice is usually reserved for chronic lung condition, that is COPD and asthma.
And there is one more interesting question asking Dr. B. Ramanaku, Ellaru, should we advise pneumococcal vaccine to adults? And for pediatrics, can we give beyond 5 years? And which he has not asked about the PCV13 or the polysaccharide vaccine. He has asked about the can we advise pneumococcal vaccine to adults?
Okay, so see, we have to see the two age bands. One is 19 to, see, we are talking about the adult vaccination. So adult starts from the age 19 years. So we have got two age bands. One is 19 to 64 years and another is above 65 years. Suppose a patient is there, 19 to 64 years, is a healthy patient, vaccination is not required. But if the patient is an immunocompetent patient, healthy patient, but he is having an underlying condition like chronic lung disease, liver disease, kidney disease, chronic alcohol intake, current smoker, definitely a vaccination is required. Those category of patients who are between 19 to 64 years, you have to vaccinate with PCV13 first, followed by PPSB23, but the time frame should be maintained at least 8 weeks or 2 months. So this is the age band between 19 to 64 years. After 65 years, the patients are more prone for invasive pneumococcal disease. So those patients, they require a PPSB23 when the patient is more than or equal to 65 years of age. So you have to see the patient, you have to see the age of the patient, age band of the patient, and you have to see the underlying chronic condition, whether the patient is having any underlying condition, immunosuppression is there, and likewise you have to decide regarding the vaccination.
Also, there is some question from Dr. Anand Krishnan is asking from Chennai whether vaccine reaction in adults in your practical experiences. Whether what type of experience did you encounter in day-to-day life or something like that, any reactions or something else?
It is as you tell about a vaccination to the patient get horrified actually. Patient thinks that something is injected to the body. But in my clinical practice till now, I have never come across with any serious side effects except some injection site reaction, or 1 or 2 patients may be having some flu-like syndrome. Nothing else, not more than that. They may be having little fever after the vaccination, or there may be some redness or induration on the injection side. Apart from that, no serious side effects or complications in my clinical practice till now. It is very safe because these are all inactivated vaccines. Because whatever the vaccines we talk today, like the pneumococcal vaccine or the influenza vaccine, they are all inactivated vaccines. So these are being injected to the individual just to promote the antibodies in the patient or the person in order to counteract the disease process in the future. So we are generating an antibody, but by injecting an inactive vaccine to the individual.
There is also one colleague asking from Nepal, Dr. Pankaj Pant, that he is asking, can other vaccine be recommended for administration with pneumococcal vaccine?
Yes, yes. Actually, all the vaccines can be given along with pneumococcal or influenza vaccination. You can give a trivalent or a quadrivalent influenza vaccine with a pneumococcal vaccination. There is no problem. But there is one vaccine which is absolutely contraindicated and should not be given. That is a meningococcal vaccine, which causes serious side effects. So the meningococcal vaccine should not be given together with pneumococcal vaccination, but other vaccinations are safe with pneumococcal vaccinations.
There are a few more questions, sir. I would like to put some more questions. Can 2 pneumococcal vaccine be given together?
I have already answered the question actually. 2 vaccines can be given together depending on the age. But if you are planning to give 2 vaccines below 64 years of age, first you have to give a PCV13 followed by PPSB23, and the gap should be minimum 8 weeks. Then the question comes, why the PCV vaccine should be given first? Why not the PPSB23 vaccine? So what PCV13 causes, it amplifies the anti-pneumococcal response to subsequent administration of PPSB23 for many vaccine serotypes. So PCV13, what it causes, it is a T cell dependent vaccine. The immunity starts longer, and once you give a PCV13 vaccine, it starts generating the memory cells. So the vaccine effect or the booster effect will remain for a longer period of time. That's why the PCV vaccine should be given first. If you compare with the PPSB23, so PCV should be given first, or 13 serovalent should be given first in comparison to PPSB23.
There are more questions, sir. And again, Dr. Achala Arya is asking, which vaccine is safe for person more than 65 years of age? You have already answered the question.
Yeah. Both vaccines are safe. There is no problem. But after the age of 65 years, if the patient has not taken any vaccination, like a native person, no vaccination history is elicited from the patient. Patient has come to your clinic, age is more than 65 years, patient is having COPD or other comorbid illness. So you have to first give a PCV13 vaccine followed by PPSV23.
So there are, sir, so many questions regarding the COVID. I would like to ask just one thing that Dr. Ram Kumar Sharma from Allahabad, he has asked how much effective would the vaccine to be prevent COVID-19 infections?
Uh, Actually, deliberately, I have not covered COVID-19 in my talk, COVID-19 vaccine, because it is in a research stage. It is not in clinical practice. We have not used the vaccine till now. So I have not covered COVID-19 vaccine in my talk. Just lastly, in a brief, I have explained about the COVID-19 vaccine. So coming to the COVID-19 vaccine, what it causes actually COVID-19, if you look at the cell structure of a SARS-CoV-19 virus, there are spike proteins are there. So what it causes actually, this spike proteins, they enter the alveolar T cells through the SE receptors. So when they enter to the respiratory mucosa through the SE receptors, they cause serious side effects. They cause a fulminant disease process. It can lead to ARDS also.
Sir, you answered a lot of questions appearing in my chat box, because there are so many questions regarding those things that whether D614G mutations, RNA virus, and something like that. You already explained these all things. Thank you very much, sir. And once again, there are few more questions, sir. Dr. Asmita is asking from Kathmandu, do all asthma patients require pneumococcal vaccination, sir? All
No.
bronchial asthma or COPD patients require?
If you see the GINA guideline, actually pneumococcal vaccination is not required for all asthmatics. That is called evidence D. That means the clinching evidence is not there. Whereas if an asthmatic is there who is having a chronic persistent asthma or a fibrotic ABPS stage, so those category of patients, probably they develop a fixed airway obstruction and they behave as COPD patients. So those asthmatics, long-standing asthma, you can go for a pneumococcal vaccination. But routinely pneumococcal vaccine is not required for asthma patients as per the GINA 2020 guideline.
And also there are few more questions, sir. How is the consensus guidelines for pneumococcal vaccination differ from SEIP guidance? So you have already mentioned in your lecture.
Yeah. Actually, this guideline, what I talked today and we are following in our country, it is a consensus guideline. It is developed by the top-notch pulmonologist in India. I think Dr. Rajadhar has spearheaded this movement, and it is published in Lung India August 20 issue also. So in this guideline, actually, there is a little bit of deviation from the SEIP guideline. The SEIP guideline says that all children should be given a PCV13 vaccine from the year 2010. So their concept is that they want to develop the herd immunity in children, and when they cross the adolescent age, by that time the herd immunity is always there. But the concept of herd immunity is not developed in India. But since India is a very prone country for COPD, asthma, or chronic lung disease, this PCV13 vaccination is incorporated now in childhood immunization practice. I think it is implemented now, because if you see the childhood immunization program, you have to give a PCV13 vaccine when the child is around 6 to 8 years of age.
And also one more question, sir. What are the recommendations of influenza vaccination in India, sir?
Uh, Actually, influenza vaccine, again, it is an inactivate vaccine. It has to be given once in a year, 0.5 ml. It has to be given intradermally, and the site of injection is a deltoid region. So it depends actually whether you want to give a trivalent vaccine or a quadrivalent vaccine. It depends on you actually. There is not much of difference between a trivalent and a quadrivalent vaccine. Quadrivalent vaccine actually contains one extra strain of influenza B virus, but trivalent vaccine injection is equally effective compared to quadrivalent vaccine. But for the safer side, it is better to give a quadrivalent vaccine. But it is little costlier. Quadrivalent is little costlier.
Also, sir, Dr. Ram Prasad Gorai from Durgapur is asking, is there any ideal month for vaccination, sir?
Actually, if you see the vaccination schedule for an influenza vaccine should be given when the flu season starts. Um, the flu season in our country varies from place to place also. So when the winter sets in or when the flu season starts, you have to start giving an influenza vaccine and you have to follow the routine schedule. So every 1 year you have to inject with the influenza vaccine.
Also, there is question from Dr. Girish Timande from Nagpur. Can this vaccine be given in lateral side of thigh in adult as it is painful?
Actually, I have mentioned in one of my slides, you should not inject the vaccine where there is an abundance of nerve blocks are there. So when where the vessels are more, it will cause more injury and it will cause more induration. It is a painful situation. So better to vaccinate in a deltoid area rather than a gluteal area.
And also Dr. Shoma Sundaram Kumarashami from Tenkashi is asking, tetanus prophylaxis after a trauma in a person who had Tdap 6 months back. For example,
Sorry, yeah.
Patient has already received 6 months back Tdap vaccination and he
Okay.
got a trauma, and should he again be given tetanus toxoid prophylaxis?
Scientifically, if you see, it is not relevant, but for the safer side, you can take a tetanus toxoid vaccine. But if you see the vaccine guideline, this Tdap vaccine should be given once in every 10 years. But nowhere it is mentioned what is the age limit of giving the Tdap vaccine. It is only mentioned that it has to be given every 10 years. But till how long to be given, nowhere it is mentioned.
Dr. R.D. Ananda is asking one interesting question. Which guidelines to follow, whether ACIP or Indian guidelines or WHO guidelines?
We are Indians, so we should follow Indian guidelines. It is very simple,
Yes.
very easy to remember, very easy to practice, no side effects, nothing is there. Because this guideline is developed by taking feedback from all the hemispheres, all the clinicians, good clinicians from India. So we should follow the Indian guidelines. It is quite mature guideline.
Also from Dr. Hazik Parvez Kaul from Bangladesh, he is asking a question, is influenza C vaccine included in influenza vaccine? Is influenza C included in influenza vaccine?
No, influenza C actually the strain is very mild form. It doesn't cause permanent disease. Actually, influenza C vaccination is not required.
Okay. And there are more questions, sir, in regarding the COVID, but I'll select only those questions. Dr. Tejasri Shetty from Bangalore is asking, is trivalent or quadrivalent better for asthmatic, sir? Again, the same question.
It depends on the choice, actually. There is nothing to say, and there is no head-on comparison trial in between the trivalent influenza vaccine or a quadrivalent influenza vaccine. So actually, if in our country, I think trivalent vaccine is more than enough, which I believe.
Also, again, one more interesting question from Dr. Sundaram Kumaraswamy from Tenkasi. The storage instructions, again, regarding the PCB 13 and PPSP 23, sir. Storage.
Same ambient temperature, 2 to 8 degrees Celsius, it is fine. There is no problem.
And again, Dr. Vijay Mohan from Chandigarh is asking, is there any special recommendation in HIV and AIDS regarding the vaccinations?
No, there is no extra guideline for all these diseases. It has to be, those patients should be vaccinated in the same formulation as the universal guideline. There is no extra precaution.
Again, Dr. Kirti Barman is asking from Chennai, respiratory vaccination.
Respiratory vaccination, actually, people are actually waiting for a COVID-19 vaccine. So this is on the horizon. It has already come. Means I think it is approved in UK. So UK will be the first country to get vaccinated with COVID-19 vaccination. So let me just brief something about COVID-19 vaccines. What are the type of vaccines actually? If you look at the COVID-19 vaccine, so there are three types are there. One is a recombinant protein vaccine. Second one is either a RNA, DNA or a vector vaccine. Third is a cell culture mediated vaccine. But most of the vaccines which are on pipeline, either they're RNA based or DNA based. I think the Pfizer vaccine is a RNA based vaccine, and RNA based vaccines are presumed to be more effective than a DNA vaccine.
I would like to, there are more questions, sir, again. And there is one interesting question. And again, Dr. Sushil Goel from Patiala, where are affordable vaccine available, sir?
Vaccines are definitely expensive, actually.
Yes.
If you compare between two pneumococcal vaccines, PCB13 is little costlier than the PPSP 23. So vaccines are definitely a costly affair. But if you want to keep the disease under bay, you want to prevent the disease, vaccination is a must when you deal with chronic lung diseases.
Yes, sir. There are so many more questions again, but due to lack of time, sir, shall we conclude or something else? Or some few more questions, sir?
Yeah, no problem. I think people will be having a lot of questions on COVID-19 vaccine, I believe.
COVID, yes, sir. Yes, sir, you're true, sir. There are so many questions regarding the COVID. There are so many questions doctors are asking about whether patient COVID, then we should vaccinate or not. And there are so many also there are few questions that how much effective would be the vaccine to prevent COVID-19 infections?
So what I have read till now, actually, the potency of COVID-19 vaccination is unknown. But some literatures, they are telling that it can give a good potency for next 6 months to 1 year. But exactly, we don't know what is the protection, what is the efficacy, and what is going to be the side effects of COVID-19 vaccine.
Also, Dr. Kamik Pereira from Ragama is asking a question. Does the efficacy of pneumococcal and influenza vaccine reduce in patient on immunosuppressives such as prednisolone?
I couldn't get the question.
Patient already on immunosuppression, such as a patient is already having prednisolone, and if we give pneumococcal or influenza vaccine, is the efficacy is there any differences between the efficacy of those vaccines?
No, not exactly. Means it is not going to hamper the immune system actually. In fact, the vaccines are being given to escalate the immune system, to magnify the immune system. I don't think the vaccines are going to create any problem in immunosuppressive patients.
Again, there are few questions from Dr. Yatin Gupta from Gurgaon. Schedule for vaccination for chronic kidney diseases. Is there any changes in the CKD?
No. In chronic kidney diseases, you have to give a pneumococcal vaccine. So pneumococcal vaccination it can be given in case of chronic kidney disease.
And also one question from Dr. Taslim Arif is, pneumococcal should also be given every year?
Pneumococcal, as I told earlier, that it is not every year actually. So if it is more than age 65 years, patient not immunized with PPSB23, first you have to give PCV13, then followed by PPSB23. The gap should be maintained at least a year. But if the patient is below 64 years, previously taken PPSB23, then when the patient crosses age 65, you have to vaccinate with PCV13 after a gap of 1 year. After 1 year of PCV13, you have to vaccinate with PPVS23. But the last PPSB23 and the previous PPSB23, the gap should be minimum 5 years.
Again,
because after 65 years, actually you should not repeatedly vaccinate with PPSB23 because it causes hyposensitization.
Again, Dr. Kirti Sisupalan is asking Bantara Valur, any indication for routine Tdap vaccine in COPDs?
Actually, for COPD, it may not be indicated, but it has been incorporated in an adult immunization program now. It was not there, but recently it has been incorporated, the Tdap vaccination, because the gold guideline also speaks about Tdap vaccination. If you see the gold guideline, it says that the gold guideline regarding vaccination has got 4 stanzas. The last stanza says that you have to give a Tdap vaccination every 10 years in order to prevent pertussis or whooping cough.
Again, one more question, sir. Dr. Rajesh Keshi from Kathmandu is again asking, can we vaccinate with influenza and pneumococcal patient with chronic lung diseases and suffering with COVID-19?
Yeah, we can give. There is not a problem. So a COVID-19 patient, actually he has suffered from a chronic lung disease. Yeah. If it is a severe form of COVID-19, patient was intubated, ARDS, that we can label the patient as a chronic lung disease. And in those patients, we can still consider of giving an influenza vaccination also.
Also, there are so many bunch of questions, sir. Dr. Jay Kishan Karahalya from Sohana, how to establish vaccination clinic in adults? Who should run vaccination clinic, doctors or nurse or pharmacist? Interesting question.
Clinician is the primary person. A clinician has to decide, either a pulmonologist or a physician or anybody who is well versed with the vaccination program. So the orders should be given by the physician or a clinician or a pulmonologist, whoever may be. So the vaccination schedule has to be prescribed. It doesn't mean that the patient should come back to your clinic to take a vaccination. You can advise a vaccination, patient can go back to their place, and they can vaccinate also. But the proper dose, site, and how to take, everything should be mentioned in the prescription. It doesn't mean that you just write Prevenal 13, 1 ampoule. It should not be like that. You have to write the dose, the route of administration, where to be given, everything has to be prescribed on the prescription. So anybody can take it out. Means you are a physician, you are giving an order. A sister can execute it. A primary physician in a local place also can execute it. But the order should be very much clear.
Again, sir, Dr. Bikashna Reddy from Sikandrabad can pneumococcal and influenza vaccine at the same visit?
You can give. There is not a problem. Both the vaccinations can be given, but at two different sites. Two different sites in the body, a pneumococcal and influenza vaccine can be given. There is no problem.
Also, Dr. Ashwin from Indore is asking an interesting question that in adult diabetics over 60 years of age, which vaccine should be given, PCV 13 or PPSV 23 or both? If both are given, then in which, what order?
Age is 60. So yes, the patient age is 60. Diabetic. So patient age is 60. See, actually what happens when the patient crosses age of 65 with underlying conditions like diabetes or other immunosuppression, the chances of invasive pneumococcal disease is very high. So since the age of the patient is 60, I will first vaccinate with PPSV 23. After a year, depending on the situation, I will vaccinate with PCV 13. Because the age is important, because the patient falls in the age group 60 years.
Also, one very interesting question, Dr. BP Agrawal from Prayagraj, do you think that heart ailments are also at risk, so be given influenza and pneumococcal vaccine?
Oh, it's a good question actually.
Yes.
So the research has shown that in a patient of coronary artery disease, if you give influenza vaccination, it reduces the mortality by almost 40 to 45%. It is as equivalent to continue the patient with a lipid lowering drug. The research has said like that. So in a patient of coronary artery disease, you can give an influenza vaccination. There is no problem because it reduces the morbidity of the disease process, and definitely the chances of secondary infection also is less.
Similarly, Dr. Ram Prasad Gorai from Durgapur is asking AE of COPD patient on steroid and came to OPD after discharge. After how many days we can vaccinate the patient?
There is nothing like that. Means, see, there is one contraindication in vaccination is that the patient should not be hypersensitive to any components of the vaccine. Second, biggest contraindication is that it should not be given in acute febrile illness time. So when you are vaccinating the patient should not have any signs of any toxemia like fever, myalgia, mainly the fever, because it should not be given at the time of acute febrile illness. But when the patient is on steroid, if the patient is fine after the steroid, symptoms are under control, patient is feeling well, you can vaccinate the patient.
Also, Dr. Sushmita Rai Chaudhary is also asking from Kolkata regarding HPV vaccine, how safe to give?
Regarding?
HPV vaccine.
HPV vaccine actually, okay. It is not routinely being given, but because it is not incorporated in the adult immunization program, but there are certain things are going on in HPV vaccination, but it has not been incorporated till now in the adult immunization program till date.
So, sir, we are running beyond the time. So, really very thankful to you and Professor Dr. Ashwini Kumar Mahapatra sir. Namaskar to you.
Namaskar. It's my privilege
I think we should conclude the session here.
Yeah.
Before concluding the session, I'd like to thank our founder chairman, Dr. N.S. Krishna sir, and all the organizing committee, and everybody, and the Chest Council of India. Thank you, sir.
Thank you. Thanks a lot, Dr. Ram. Thank you, CCI.
Thank you, sir.